Hello, everyone. It is noon, so we will go ahead and get started. My name is Lisa Nagel. I'm from the Center for Collaboration Advancement in Pharmacy, the CAP Center here at NDSU School of Pharmacy in Fargo. We are pleased to welcome you to our series on chronic disease and have you join us today as we dig into the latest advancements and updates in the management of hypertension. As pharmacists, your role is essential in ensuring optimal patient care, particularly in chronic conditions like hypertension. Our webinar today is called Managing a Silent Killer, an evidence-based update on hypertension treatment. I do have a few housekeeping items to quick go over. We would like you to please utilize the Q&A function for questions during the webinar, and we will save all the questions till the end. This webinar will be recorded and available for viewing and continuing education after today. The recording will be placed on our CAP Center website and the CAP Center YouTube page. After completion, I will send out all the information to the participants today. Please feel free to share this with your colleagues or your students. The CE information will also be provided at the end of the webinar. With that, I am so excited to welcome our expert speaker for today. Dr. Joseph Saseen is an Associate Dean for Clinical Affairs, a Professor of Clinical Pharmacy, and a Professor of Family Medicine at the University of Colorado Anschutz Medical Campus. He has responsibilities for enhancing the school's clinical enterprise, further developing sustainable clinical service models, advocating for advancing the practice of pharmacy in the state of Colorado, and managing strategic international relationships. Dr. Saseen is a clinical pharmacist who focuses on cardiovascular risk reduction and population health. With that, please take it away, Dr. Saseen.
Well, great. Thanks so much for inviting me, Lisa, and for that wonderful introduction. I am a pharmacist myself. I've been a pharmacist for several years now, even though I do have some other administrative duties here. My administrative duties focus on clinical care in the ambulatory setting, and the pharmacists that we have that work for the School of Pharmacy are engaged in collaborative practice agreements where they manage hypertension in addition to other cardiovascular conditions and things like diabetes, which are very common. I don't have any disclosures that are relevant for today. We won't talk about any off-label use of medicines. But before we get started, I would like to share with you the learning objectives and then some pre-questions. So here are learning objectives: to interpret our guidelines, which are the 2017 ACC/AHA guidelines, discuss the evidence about blood pressure lowering, and specifically some of the goals that we have, how robust those evidence bases are is really going to be important for us, and to talk about resistant hypertension, which is something which requires often the assistance of both the primary care provider and even a clinical pharmacist. So at this point, Lisa, could you launch the questions that we have? We'll give everybody about a minute or so to answer these questions. You should see a poll with 4 different questions, so take your time and answer those. Should take about a minute or so. And don't fret if you weren't certain about your answers at all. We will definitely cover the content and make sure that everybody has an opportunity to learn from this session, hopefully. I want to start off with why this is relevant. So I always look at the American Heart Association to get a feel for how common cardiovascular disease is in the United States. They update statistics every single year. So these are their 2024 statistics. And you can see what they plot on the left are millions of Americans that have cardiovascular disease and then certain kinds. So these numbers should jump at you as staggering. We have about 350, 360 million people in the United States, and almost 122 million of them have hypertension. That's an awful lot. That's about, 1 in 3 patients that we might see that have definitive hypertension. This is adult population. Some estimates go as high as 50% if we use the most stringent blood pressure goal. So I use this as an example is there's a lot of people out there with hypertension, and they also have other things like coronary heart disease at a lower prevalence, but that's really the reason we treat hypertension is to prevent the development of things like coronary heart disease, stroke, heart failure, and organ disease failure such as kidney failure. The American Heart Association also promotes what's called Life's Essential 6, and this is not rocket science. It's things such as eating well, getting a regular aerobic exercise, if you have diabetes, controlling that. But Right on the left there in the purple, that little blood pressure cuff highlights that measuring and managing hypertension is really important. If you're wondering, hey, I've heard of this before, and it was used to be the 7, Life Simple 7, they used to call it. They added 8, and it was the importance of getting a good night's sleep and getting adequate sleep. That's the newest addition to make it an 8. All of these are strategies to have a heart healthy life. Let me give you a patient to put this into perspective. I want you to meet John Doe. What do we know about John Doe? He's a 47-year-old black man with a history of hypertension, dyslipidemia, chronic kidney disease, and prediabetes. Maybe you've seen a patient like John Doe in your practice, or you've encountered maybe a relative or a friend that it looks like this person. What we know about this 47-year-old man is that his family history is not very positive. It indicates he had a father who died of an MI at age 50, which is considered premature. John Doe is a former smoker. He lives in a very disadvantaged Denver neighborhood. He doesn't follow any specific diet. He drinks 2 to 3 alcoholic beverages a day, doesn't exercise. He has Medicaid as his insurance. I'm not sure what his employment status is right here, but we do know he has Medicaid. His medications are pretty simple. He's got hydrochlorothiazide for his hypertension and atorvastatin 10 milligrams a day for his dyslipidemia. It's only 2 drugs, both generic, affordable options. His blood pressure is 142/88, and this measurement is similar to what is measured at home. He has a home blood pressure cuff, and he does measure it, getting about the same values. Heart rate's 80 beats per minute. His BMI is really, really close to being obese. His fasting lipid panel is listed there. His LDL is actually pretty high for being on atorvastatin at 144, so I'm not sure he's taking it, or if he is taking it, he's got really bad dyslipidemia. His A1C clearly is prediabetes. His serum creatinine is elevated. He does have that G3A2 chronic kidney disease, that stage 3 chronic kidney disease. His estimated GFR is in the 50s, which is not good for a 47-year-old person, and he does have the presence of albuminuria. That's the urine albumin creatinine ratio is 64. Lastly, this person did have a scan of his heart, and he has early signs of subclinical atherosclerosis, which is a positive coronary artery calcification test. The provider probably wanted some further insight to whether this person has advanced disease or is starting to develop disease, and there was some markers that something's starting in those arteries. So this is of concern. You may think to yourself, what is, the future hold for this patient? And you should be concerned about his cardiovascular health. If you want to quantify it, what's recommended is the pooled cohort equation. Maybe you have done this in your practice. You can have an app that's on your phone, or you can actually log into the website, which is listed below here. This is the American College of Cardiology and the American Heart Association's recommended risk estimating tool for primary prevention patients, meaning people that have not yet had a cardiovascular event. And it's not a perfect thing. If you put in John Doe's characteristics, which are all in this blue box here, you can get his risk for future major hard ASCVD over the next 10 years and then within his lifetime. And if you put in his numbers, he scores out at 10.9%, which based on interpretation here is considered intermediate risk. Now, his lifetime risk is 50%, which isn't surprising because most people in the United States die of heart disease. So that lifetime risk should not surprise anybody at all. But there's more to this guy. 10.9% doesn't seem that high. He has some elements in his history which are incurring risk, which aren't in this risk calculator. We see that there's a great amount of things here like race, blood pressure, cholesterol numbers, smoking status, but it doesn't incorporate the risk that's incurred by his kidney disease, his prediabetes, or his coronary artery calcification test being positive, showing that there's some subclinical atherosclerosis. So there is actually a newer equation. It's called the Prevent Equations, a newer tool by the American Heart Association that just was released a couple of months ago. And this is said to be an improvement in the pooled cohort equation. It's better. Now, what's better about it? Well, it's newly developed. It's still sex specific, so it's different for men versus women, but it's race agnostic. You don't need to know somebody's race, and it's always been a bit questionable with the pooled cohort equation is when you have to answer, is your patient African American or not? That's the term that they use. How African American is it? How about people with mixed race? What about people from other ethnicities? So they found a way to actually build a cohort of epidemiologic data and create an equation out of it that doesn't require race, which is an improvement because there's a lot of variability when we add race. You think it'll be better, but it's not always the right thing to do. This gives you 3 different numbers. It gives you a prediction for total ASCVD, total CVD, which includes heart failure, and then just heart failure alone. So three different elements here. It includes kidney function, it includes glycemic measures such as A1C. And for patients where you have their zip code, you can put in their zip code to get social determinants of health and the risk that's incurred with that. So you'll see a lot more about this preventive equation. It's probably going to take over for the pooled cohort equation. So I just wanted to share with you how it impact John Doe. If we add in these other elements, we'll get, same baseline demographics, except we have the addition of urine albumin creatinine ratio, A1C, and zip code. We can see three different risk predictions. There's a 10-year and a 30-year estimation for cardiovascular disease collectively. And instead of 10.9, it goes up a little bit to 11.1, but we see that 30-year risk. 30 years a little bit better than lifetime risks. Lifetime, people have a hard time sort of visioning, in my entire lifetime having disease. 30 years is maybe a better forward-thinking measure. And this man's only 47, so that's maybe a little bit more meaningful long-term for him, with specific risk of ASCVD, and then heart failure too is incorporated here. So a more robust calculator, and it really is telling me even, next 10 years don't look good. He's only 47, but going beyond that is occurring a lot more risk. So you may want to be more aggressive with his hypertension management. Let's dive into that. The American College of Cardiology, in collaboration with the American Heart Association, published this guideline. It's the 2017 recommendations for treating and managing hypertension. And just like all cardiology recommendations that come from this group, every time they recommend something, they have a classification and a level of evidence. And how is this helpful for you, where you can actually see the evidence base for these recommendations? The classification is how much benefit outweighs risk. So a class 1 benefits clearly outweighs risk, where something like a class 2B recommendation is considered weak, and benefit and risk of that recommendation are close to one another. We have some red things, which are just recommendations of things not to do. The level of evidence also gives you insight. It's either A, B, or C. A is the best. C might be expert opinion. So the higher the level of evidence, the more studies and proof that we have to back up that recommendation. So I'll lean into this when I'm going over some of the specific recommendations for John Doe or for other people with hypertension. So the first recommendation I want to focus on is measurement of blood pressure. These are high classifications, class 1, with either expert opinion or A-level evidence. And this makes sense. The first one is when you're diagnosing hypertension, we want to make sure that people have proper methods. This is an expert opinion, but it makes a whole bunch of sense. You want to make sure that that measurement is accurate, because we have the problem where blood pressure is measured incorrectly all the time. So really using confirmed more than one measurement that's accurately measured is very important. There's also an emphasis on getting, and this is a class 1A recommendation, out of office blood pressure measurements. These are used for diagnosing and managing, often through home blood pressure monitors. Some people can have an ambulatory monitor that stays in their arm for 24 hours. That's less common. It's more common that patients buy a cuff and they actually do their own measurements in the morning. It can enhance telehealth. It was used during the pandemic quite a bit, and a lot of our pharmacist protocols require the use of that out-of-office measurements to make titrations, not just for diagnosing. It can help with masked hypertension or white coat hypertension too, because you get sort of the blood pressure that people live at home. Now, why is measuring blood pressure accurately so important? Well, you need an appropriate device. So even if it's a home blood pressure cuff, you want to make sure that it is periodically validated against a definitely accurate measurement, like what might be done in an office setting. We see that there's some other information here about these home blood pressure devices, that ones that have memory that are embedded in the device are preferred. We have patients actually do more than one reading at a time. They should still wait 3 to 5 minutes before doing the first reading to make sure that they're period of rest. Because if you don't do this, here's the problem. These are all the things or errors that can occur. And the incorrectness in measurement that can actually result from this. If you put the cuff over clothing, you can have a blood pressure measurement that's higher by sometimes 10 millimeters of mercury. If patients have a full bladder, meaning they have to urinate, they're holding it in while they're during the measurement, that can raise their blood pressure. When people are talking during the conversation, having a conversation during the measurement, that's a problem. Having a patient have an unsupported arm, meaning it should be resting on a table and not sort of lifted up or lifted down. They should have their feet on the ground and their back supported and their legs uncrossed. These are all the things that we recommend in addition to the 3 to 5 minute period of rest, which result in a most accurate blood pressure reading. So message here is, if you're managing blood pressure, make sure that the reading's done properly, even if your person's doing it at home. So what's considered normal and what's not considered normal from a hypertension standpoint. We have this categorization. We see systolic blood pressure and diastolic blood pressure values here. Normal is being a systolic less than 120 and a diastolic less than 80. That's the ideal situation. But then we have people that fall into the elevated range. Their diastolic still is less than 80, but that systolic is in the 120s. These are people that are maybe at risk for developing hypertension as they age, because clearly we have stage 1 and stage 2 hypertension. That's when a patient's systolic blood pressure is 130 or higher, or their diastolic is 80 millimeters of mercury or higher. Either one can occur. So, for example, if you have somebody who has a blood pressure of 135 over 70, they have stage 1 hypertension because the systolic is there. I don't care if the diastolic is normal, the worst case prevails. We sometimes have people that have a blood pressure of, let's say, 124 over 95, and 124 over 95 seems odd, but that's a younger person blood pressure. That would be considered stage 2 because the diastolic is in that range. So the worst case prevails, stage 1 and stage 2 hypertension, both of which are above 130 over 80. Now, what else is recommended in these guidelines? So, in addition to measuring blood pressure correctly, we do have a very strong recommendation to use a goal blood pressure of less than 130 over 80. I just came back from the American College of Cardiology meeting in Atlanta, and they all agree. They've agreed since 2017. That's a long time that this is the proper blood pressure goal. We see that the class of recommendation to support that is a class 1. And the evidence is maybe not an A level, but it's because in blood pressure studies, not everybody gets to the same blood pressure measurement. And there's usually a range or a span of blood pressure measurements. So that's why we see that level of evidence is at best a B, and it really is just a marker of the evidence that was done. But still, very high confidence that using a blood pressure goal less than 130 over 80 is appropriate for some people. There's a little bit less confidence if you look at that 2B recommendation, and these are for your low risk patients, those who have a cardiovascular risk score of less than 5%, that perhaps, or 10% sometimes even, that maybe the blood pressure goal is still a less than 130 over 80, but with a little less confidence because we have less data looking at healthier people. Surprisingly, though, when we look at older people, age 65 or older, which isn't all that old, we have a class 1A recommendation to get that systolic less than 130. As people age, their diastolic drops down, and most people have a problem with their systolic being elevated. So that's a very strong recommendation to get that less than 130, the systolic, in our people 65 or older. And that's for the majority of our older population. Now, there is sort of some pushback from the American Academy of Family Practitioners. They recommend higher blood pressure goals. They recommend a less than 140 over 90 or a less than 135 over 85. And this is really, they just interpret the data differently. They're not aligned with the cardiologists. The AAFP group is not. So you may see some pushback, but I guess all guidelines at least recommend less than 140 over 90. I prefer less than 130 over 80 for my patients because I care for them and I really want them to actually have less cardiovascular disease, but recognize that there are some organizations that push for a slightly higher goal or a more traditional approach. And that really is based on how they interpret the data. Now, I do want to share with you the evidence to support less than 130 over 80 as the appropriate blood pressure goal. And this gets a little confusing. So you have to acknowledge this. We have a ton of studies that have looked at patients at treated to different blood pressure goals. And just like spaghetti thrown at the wall, you can see that where their average blood pressures is all over the place. So what this particular study did is they looked at 42 hypertension clinical trials, which had almost 150,000 patients, almost that in their population. And they put them all together and they looked at their incidence of cardiovascular disease transposed against their average systolic blood pressure during the trial. And they made some comparisons. They compared people with, an average on the low side versus average on higher sides. If you see here, all these comparisons are people that were on average a systolic in the low 20s versus higher levels. And there was, when you compare people in the low 120s to people in the 130s, there was fewer cardiovascular disease events in the 120 group versus the 130s group. If we look at the hazard ratio, that's telling us that there's about a 30% relative risk reduction in cardiovascular events when you treat people to the 120s versus the 130s. And to me, that's like comparing a goal of less than 130 to less than 140 because people end up being a little bit below that on average. So here's some of the proof. Also, if you let people sit at higher systolic values, they have more cardiovascular disease events. So that's really disappointing to see. So this is some of the proof to support the lower blood pressure goal, or the ACC, American College of Cardiology, recommended blood pressure goal of 130 over 80, less than that value. There's also some other studies, and one that is, very, very big. And this was a while back. This is almost 10 years ago, the SPRINT trial. If you haven't heard of the SPRINT trial, I'm going to give you the summary really quickly. They actually took patients, almost over 9,000 patients who had hypertension, age 50 and older, with an additional cardiovascular risk factor. And they randomized these patients to intense blood pressure lowering, which is a systolic of less than 120 versus the standard of less than 140. And you may think, oh, why are we recommending 130 versus less than 120? It's because a lot of the people in that tight intensive group didn't quite get less than 120. The average blood pressure there was about 122 versus about 139 in the less than 140 group. So we're comparing people in the low 120s to people in the high 130s, and basically in this group. There were some exclusions, like people with diabetes were not included, or heart failure, but they looked at cardiovascular events. And if we go to the right, this is the percentage of patients in these two groups that had a cardiovascular event at 3.3 years, which was the duration of the study. And you can see the hazard ratio was 0.73, which means it was a 27% relative risk reduction with the intensive treated group versus standard group. And that was proof that lower is better. Now, some things that you might ask, what about old people? Old people more frail sometimes. Did they do just as good? They didn't do just as good. They did better than the average population. If you look at this first line up here, we see that the age here, I'm going to actually get my pointer up here if I can. Let me get the pointer. And if you look at this age difference between people that were less than 75 versus greater than 75, here's their hazard ratio. The people that were older did better. They had a 35% relative risk reduction in a cardiovascular event versus just 21% in the younger population. So both of them were good. Both of them actually had fewer cardiovascular events, but we got more bang for our buck in that population than we did in the younger population. So older people benefited. There was a benefit in men and women, Black patients versus non-Black patients, and even if they had previous cardiovascular disease in this particular study. What you might be wondering is, what did it take to get people intensely treated to that less than 120 goal, which means they sat in the 120s, so less than 130 according to our current standards. It took a few more medicines. On average, intense treatment group patients needed 3 antihypertensive drugs versus the standard group required on average about 2. And when you use more drugs, you can expect that you'd have more side effects. So that is true. There was more hypotension, more electrolyte abnormalities, and cases of acute kidney injury. The absolute differences were small, but they were more common in the intense treatment group, which is what you would expect because you're using more medicines. So I say this with full acknowledgement that when we treat patients to goal, we do have to monitor them for drug-related side effects, which is a wonderful role for pharmacists. We can treat them to the lower goals to protect their heart, think of it that way, but we also can do the monitoring to prevent undue adverse effects. Now, the one thing about the SPRINT trial is it was mostly white and Black patients in that particular population. There's some data actually looking at Chinese patients it's called the STEP study. This came out of China. It was published in New England Journal of Medicine. Almost the same kind of study design. They looked at thousands of patients and they randomized them to intense blood pressure lowering versus standard blood pressure lowering, and they looked at cardiovascular events. And same kind of phenomenon. There was a 26% relative risk reduction with intense treatment versus standard treatment. And this was good. So it extends some of these benefits to the non-white, non-Black population we might see in the United States. So now that we understand sort of how to measure blood pressure, what the different categories are, what the blood pressure goal is, we can transpose it into how to treat. So this algorithm comes from those 2017 cardiology guidelines for treating hypertension, and it categorizes patients having normal blood pressure, elevated blood pressure, stage 1 or stage 2. The easiest to explain is if a patient presents in stage 2 hypertension, it means that their systolic is 140/90 or higher. What's recommended is both non-pharmacologic therapy and medications at the same time. Matter of fact, some of these patients may warrant 2 antihypertensive drugs, and I'll come back to that point. And then you reassess in a month. If you have somebody who's stage 1, which means that their blood pressure is elevated, it's above the 130/80, but it's really close to it. You look at their cardiovascular risk, and you can do the pooled chord equation, or you can actually do the prevent equations and look to see if their risk is 10% or higher. If the risk is 10% or higher, you're going to go to the right of this algorithm here. You're going to institute non-pharmacologic therapy and medication and reassess in a month. If your patient has low risk, meaning the answer to this is no, meaning it's less than 10%, then you have a little bit of time. You have up to 6 months to do non-pharmacologic therapy alone to see if it works. And if it doesn't work at that time, it's recommended to start antihypertensive medicine. So it is pretty, I don't want to call it aggressive because it's been recommended for a while, but drug therapy is recommended pretty early on in most patients who present with hypertension. That really is because not treating it is this asymptomatic condition is negligence. Remember, most people with hypertension don't have symptoms that their blood pressure is high, so it makes it a challenge to treat them because they don't feel bad, but we need to treat to prevent future harm. And this is sort of the landscape of what we have to deal with. Lifestyle modifications do work if people follow them. These are all class 1A level of evidence recommendations, everything from weight loss in obese or overweight patients to eating a healthy diet that actually is high in fruits and vegetables and low in saturated fat, sodium reduction to ideally less than 1.5 grams a day, potassium supplement through diet, mostly through green leafy vegetables, physical activity in a structured program, and not drinking excessively. And the drink cutoffs are 2 drinks or less for men and 1 drink or less for women. And fortunately or unfortunately, the definition of a drink is 1 drink equivalent. So 5 ounces of wine, 12 ounces of beer, not a pint, but 12 ounces of beer is 1 drink equivalent, and 1.5 ounces of hard alcohol. I say that because sometimes people underestimate their true alcohol ingestion when they just say, oh, I have 2 to 3 drinks a day, because their servings might be large. As far as drug therapy, this is what's recommended. We have 4 first-line medicines which have a class 1A recommendation. So these are first-line drugs for most people with hypertension: thiazide diuretics, calcium channel blockers, ARBs, and ACE inhibitors. All 4 of those are considered equally good long-term. They've been proven not only to lower blood pressure, but they've been proven with a class 1A recommendation to reduce cardiovascular events. So those are the drugs that we should be working with in most of our patients. Thiazides, calcium channel blockers, and either an ACE inhibitor or an ARB, we don't use them together, but those are the first 3 tiers with 2 options within the last tier of what we should use before we start dipping into some other less common drugs. We also see a class 1 recommendation for patients who are far from their goal. These are people with stage 2 hypertension who require at least a 20 millimeter mercury reduction in their systolic blood pressure. What's recommended there is to start with 2 antihypertensive drugs as initial therapy. We have lots of options. They're available generically, and they do work at lowering blood pressure. The average is that most of these people will require 2, if not 3 anyways, in the long term. So getting a combination product for these people far from goal instituted early is the recommendation. It's been the recommendation for decades, actually. People just don't always follow it. We see some other somewhat insightful recommendations. I don't love all of these. This one here, it says Black patients who don't have heart failure or kidney disease. Initial treatment probably should be more of a thiazide or a calcium channel blocker. If you're using just 1 drug in your Black population, a thiazide or calcium channel blocker will give you the most reduction in blood pressure. If you're using 2 drugs together, everything's good. But the only problem here is when you use an ACE inhibitor or an ARB as monotherapy in a Black patient, you might not lower blood pressure as much as when you use it in combination with something else or switch to a thiazide or a calcium channel blocker. Somewhat of a moot point because we're dealing with really polypharmacy and hypertension, which is a 2-drug disease, if not more. And we see that in Black patients, they often require 2 or more antihypertensive agents. I call this out a little bit because it's in our guidelines, but we see that in our typical Black population, the burden of disease is a little harsher in that population, meaning that the risk for end organ damage like kidney failure and heart failure is higher in Black patients than it is in white patients. I don't know the exact reason why. It may not be physiologic. It may be because of the attitude that we have for treating them, or maybe they're falling through the cracks in some ways, or they have less access to healthcare. But it is true that they're at risk for more severe consequence. So perhaps a little bit more aggressive recommendations for that population. There are some things I just want to bring up as food for thought. Sometimes when patients have stable ischemic heart disease like angina, or they've had a heart attack, or if they have diabetes, or if they have kidney disease, or if they've had a history of a stroke, we may not just pick from one of those 4 antihypertensive top 4 drugs or first-line agents. We may pick one specifically. For example, if somebody has angina, we would want to use a beta blocker first, and a beta blocker is not even in the top 4 drugs. but it's a special drug that not only treats hypertension, it also actually works for stable ischemic heart disease. Unless there's a good reason to use a beta blocker, we don't use a beta blocker. Heart failure is a good reason, so is stable ischemic heart disease. Kidney disease, really good reason to start with an ACE inhibitor or an ARB first, even if your patient's black. I don't care about how much their blood pressure may or may not go down. It's needed because of the long-term beneficial effects that ACE inhibitors and ARBs have on the kidney. So look at these if you have a patient with what was called a compelling indication for something different. Some other recommendations, evidence-based recommendations that we have from this guideline is when to follow up and what to follow up with. Well, that class 1 recommendation up there right at the beginning, a class B recommendation is to monitor in monthly intervals. So after you start a drug, make sure that we recheck blood pressure to see if we're at our goal in 1 month intervals, so about 4 weeks. We also should not just look at blood pressure lowering, but ask about adherence too. That's really important, and look for markers of adherence. And this other recommendation, a class 1A recommendation, is that follow-up and monitoring should use systematic strategies like blood pressure monitoring at home, team-based care, and telehealth strategies. That team-based care does include pharmacists, and there's a lot of momentum to get pharmacists more and more involved in the management of hypertension because patients need help and there's not enough clinicians to go around. Now, I want to come back to a combination therapy that push where people are far from goal, that they need 2 drugs as initial therapy. It really is because 2 drugs together work better than 1 at maximum doses. This is a great little study. It looked at 42 different trials, and it looked at the blood pressure lowering with 1 drug alone, a different drug alone, or using both together versus placebo. And they looked at the overall additive effects. So when you look at thiazides, beta blockers, ACE inhibitors, calcium channel blockers are all classes together, which included a very small amount of ARBs, but they pretty much respond the same as an ACE inhibitor. When you look at the green bar, that's the additional reduction you get, the observed expected additive effect in blood pressure lowering that you get from adding 2 drugs together versus just doubling the dose. So the gray bar is doubling the dose, the green bar is adding another drug, and how much extra you get. Overall, this really does tell the message that using low doses in combination are better than using the maximum dose of 1 drug as monotherapy. You get most of your blood pressure reduction with the initial dose, believe it or not. The only times we try to maximize the highest dose are mostly with ACE inhibitors or ARBs when we're trying to get benefits for the kidney or benefits for people with established heart disease. That's really the only time we do that. If you're thinking about combinations that are good and bad, or maybe ones that are just unproven and probably good, this 6-sided diagram actually is helpful. This comes from European guidelines, and it has basically the 4 major antihypertensive classes like thiazides, ARBs, calcium channel blockers, ACE inhibitors. But on the left, it includes beta blockers and some other agents like clonidine or hydralazine, or even alpha blockers. And anything that's connected in a green line represents an effective combination. So we see thiazides with anything or calcium channel blockers with just about anything are usually additive good combinations. You can use a beta blocker with a thiazide that's connected with the blue line there, and that implies that it's probably useful, but it has some limitations because of the metabolic side effects. The dotted black lines are possibly really good combinations, but less well tested. And that red line connects an ACE inhibitor and ARB, and that's something we should avoid doing. This is a class 3 recommendation in the guidelines, meaning don't do it because of harm. So never use an ACE inhibitor with an ARB because bad things happen, and it's not recommended. You should use another drug. Now, the world of combination therapy, there's plenty of options for pharmacists. If you look here, these are all different common combinations. These are true drug combinations on the left, which include ACE inhibitors or ARBs with thiazides, and sometimes an ACE inhibitor or an ARB with amlodipine, which is great. All of these on the left are available generically. We even have on the right some off or less common combinations like a beta blocker with a thiazide. But look at the bottom there. We have a 3-drug combination, an ARB with a calcium channel blocker with a thiazide. There's actually 2 of them, and they're generic. So I share these as options for some of your patients that may be hindered by pill burden, that sometimes using the combination pill, the fixed dose combination pills, once you know you have the drugs that you want instituted, converting them to that may save a copay and may actually make using drugs a bit easier for some of your patients. There has been a study, a really nice study I like referring to, looking at 2 different 2-drug combinations and showing that one was better. This is called the Accomplish trial. Over 10,000 patients were in this trial, so big one, over 11,000 actually. And they evaluated benazepril with hydrochlorothiazide versus benazepril with amlodipine. So same ACE inhibitor, just one had an addition of a thiazide, one had the addition of amlodipine. They looked at cardiovascular events. If you look to the right, people treated with the ACE inhibitor and amlodipine had fewer cardiovascular events than people on benazepril with hydrochlorothiazide. So this tells me that when we're using combinations, most clinicians would go with hydrochlorothiazide as the second drug. This tells me maybe amlodipine would be a better second drug if somebody's on an ACE inhibitor or even an ARB for that matter, because of the positive effect long-term on cardiovascular events. Hydrochlorothiazide is a great drug. It's used everywhere. It's in all those combinations. Both combinations are good to me. But when push comes to shove, I think you can say that the combination with amlodipine is better than the combination with the thiazide. Overall, with these agents, I do want to highlight that as we think about the SPRINT trial and going to lower blood pressure goals, we have to be in tune to the side effects that might occur. And this is where pharmacists come into play. These are all the common antihypertensive classes. I even put in down there beta blockers and mineralocorticoid receptor antagonists, which are drugs like spironolactone, the kind of things that we need to think about. Some of these require blood tests to test for elevated potassium or changes of kidney function. That is the case for ACE inhibitors or ARBs, and then for thiazides to some extent. Calcium channel blockers really don't. They may have some drug interactions with verapamil and diltiazem, but overall, we just look at blood pressure, heart rate, and then for symptoms like edema that might occur as a side effect. Beta blockers have lowering of heart rate, which may be a problem in some patients, or bronchoconstriction in patients who are treated with a non-selective beta blocker. That's mostly in our asthma patients. And then MRAs like spironolactone can cause pretty significant high potassium levels. So we have to look for that. I want to add this in here, just food for thought of things that we need to look at when we're monitoring patients to ensure safety. Another thing that should be in the back of your mind is I've mentioned kidney disease a few times. If anybody's familiar with Tina Turner, she's a very famous person who passed away. And her cause of death was she had long-term kidney failure because of uncontrolled hypertension. So even people with very good access to healthcare can still have problems once they have hypertension, and it can affect their kidneys. If you have somebody with chronic kidney disease, there's a growing body of evidence. Matter of fact, the KDIGO group just released their updated guidelines in 2024. It basically says there's evidence showing that even lower blood pressure values in kidney disease are better than higher values. And they recommend, if you look at the bottom here, a systolic blood pressure goal less than 120. And it's because of some evidence that people with established kidney disease, to decrease the burden on the kidney, we may need even lower blood pressure goals. So maybe keeping in the 110s, it should be a good target there for those patients. That's definitely require monitoring for hypotension and other side effects because of the burden of drugs that would be needed for that. Despite good efforts, we may have patients that have what's called resistant hypertension. What is resistant hypertension? Well, it's basically a patient that is on 3 antihypertensive drugs, 3 of the good ones. So a thiazide diuretic, a calcium channel blocker, and either an ACE inhibitor or an ARB. So those 3 combinations from the top 4 list, smartly used together at good doses. And if a patient's still not at goal on those 3, at good doses, then they're said to have resistant hypertension. Or any patient who requires 4 or more antihypertensives is considered resistant hypertension. Now, often the causes, if you look to the right, the most common reason why somebody actually may look like they have resistant hypertension, but they don't truly have it, is that they're undertreated, maybe because they're not adherent, or they have an inaccurate blood pressure measurement. So this is a lot of the patient populations that we see in clinical practice, because these are the hard ones to manage, and they come to us as clinical pharmacists to help out. For resistant hypertension, you got to think, being on these many drugs, you got to think, why is somebody's blood pressure high? Well, rule out other common medications, which are secondary causes like excessive NSAID use, oral contraceptives that contain estrogen. Sometimes some stimulant medicines can do this, excessive alcohol, cocaine, some anti-rejection drugs like cyclosporin or tacrolimus, or even some diseases like sleep apnea or kidney disease may actually be the secondary cause why somebody doesn't have blood pressure lowering and goal achievement with multiple drugs. With resistant hypertension, we have had some advances. This is not a recent advance. In 2018, the American Heart Association put out a scientific statement on how to manage patients. And let's step through this a little quickly. Step 1, if you have a patient that looks like they're on three drugs at full doses and still not at goal, make sure that the doses are optimized, that they're actually at full doses. Make sure that they're following lifestyle modifications and they don't have secondary causes. And once you've done that, they recommend step 2, looking at that thiazide. And if the thiazide they're on is hydrochlorothiazide, this guideline in 2018 recommends switching to chlorthalidone, or even indapamide is perhaps a stronger thiazide. I'll come back to that point because this step 2 is a little controversial now. But if that doesn't work, they recommend thereafter not going to a beta blocker. They recommend going to a drug like spironolactone. The only time you'd be cautious if a patient's at risk for high potassium, like if they have really bad kidney function, but they recommend spironolactone ahead of a beta blocker because most of these people that have resistant hypertension, they have too much aldosterone in their system, and a mineralocorticoid receptor antagonist blocks aldosterone. That's why it raises potassium to a point where it may control their blood pressure. Thereafter, that's when we start thinking of a beta blocker. So a beta blocker in here might be going down to our fourth or fifth drug option. So it's way down the line there. It may a beta blocker that also can block your alpha receptors like carvedilol may be a little bit better. You may have some other options there. If a beta blocker doesn't do it, that's when we start dipping into some less common drugs like hydralazine. And then as a last option in this algorithm is minoxidil. Minoxidil is, we think about it being Rogaine to help grow hair and because of the high amount of side effects. Hydralazine is not a walk in the park. People get tachycardic from that drug, but minoxidil has worse side effects than hydralazine, so it would be recommended after hydralazine. There's a lot of detail on this one. This is maybe one that you print off and you keep it to the side and you sort of digest it because there's a lot of detail in here on how to treat resistant hypertension population. Now, when I said that the thiazide is a little controversial, here's what's not controversial. When you look at hydrochlorothiazide versus chlorthalidone, chlorthalidone's always been viewed as stronger. It's got a longer half-life, and it's said to lower blood pressure better. Now, it's a little bit confusing because even though it lowers blood pressure better, it's been studied. If you look to the right, there's a lot of controversy that started in 2020 where they compared people treated with hydrochlorothiazide to people treated with chlorthalidone, and both were good. There was no difference in cardiovascular events. So, switching people from hydrochlorothiazide to chlorthalidone might not be worth it because it might not reduce their cardiovascular event risk. And even though it might lower blood pressure more, maybe it's not a full lowering, or maybe it's not for 24 hours. There's a little bit of cloudiness here. I feel less. So if I go back one slide, I feel less enthusiastic with this step 2 of switching thiazide diuretics based on this data. Matter of fact, even another study called the Diuretic Comparison Project did the same. It compared it. This one came out in New England Journal just 2 years ago. It looked at VA patients and it looked at hydrochlorothiazide versus chlorthalidone, and there really wasn't a significant difference in primary endpoints. So you can switch people from hydrochlorothiazide to chlorthalidone. I'm not sure it's really worth it anymore. So I'm not much of an enthusiast of doing it based on these data. One thing that maybe is better is think about after you're on your top 3 drugs, which is a thiazide, a calcium channel blocker, and an ACE inhibitor or an ARB, adding spironolactone is the recommended next step. When you look at a comparison from the Pathway 2 trial, this compared adding spironolactone or doxazosin, which is an alpha blocker, or bisoprolol, which is a beta blocker, or nothing, and looked at systolic blood pressure decreases. And you got more reduction with spironolactone than you did with the other comparators. The only downside was you had patients that had some hyperkalemia, which has to be monitored for, but that mineralocorticoid receptor antagonist, which is spironolactone, really had high efficacy in controlling blood pressure in this population. That American Heart Association statement did talk about some drugs I haven't mentioned much anymore. One are clonidine, which is a centrally acting alpha agonist. I've seen clonidine used a lot, and it probably shouldn't be used, especially the oral pill. Now, why do I say that? Clonidine has a lot of anticholinergic side effects and has rebound hypertension if you stop it abruptly. So that's actually a real problem with some patients. Because of those complications with use, take a look at this statement from the American Heart Association. They say clonidine tablets should be avoided because of the need for frequent administration and the risk of rebound hypertension. They further, and this is not on the slide, but I want to say this very emphatically. They further say that if you must use clonidine for hypertension, use the transdermal patch, not the pill. I don't see people doing that. But the pill can cause rebound hypertension because when you stop it, it goes away so quick. At least the transdermal patch is longer acting. This would be my last ditch effort, my last line option. And when I say last line option, was a new medicine approved in March of 2024. It's called aprocitentan. It is an endothelial receptor antagonist, a dual one that affects 2 different types of endothelin receptors. And it is the first new drug class that we have in 30 years. There was this renin inhibitor called aliskiren. It's not really available anymore. That was in the meantime, but 30 years ago is when we had the introduction of ARBs into clinical practice. Now we have an endothelin receptor antagonist, aproposentant. It's a hard one to say, but that's what it is. And it's an oral drug given once a day. And if you look to the right, it's not I'm not doing cartwheels because when you look at placebo versus the 2 doses of aproposentant, there was an additional reduction in blood pressure with this agent. Not much of a difference in the 2 doses. So, that's why we had 12.5 milligram oral dose. That's the recommended dose. It's not perfect. There's issues with having to monitor liver function tests and a high incidence of fluid retention and edema that occurs. So that is what we have. This is the newest resistant hypertension drug, and be on the lookout. There's going to be other new chemical entities, ones that use siRNA technology, drugs that inhibit angiotensinogen that are being evaluated in phase 3 trials to reduce blood pressure. There's even one that actually decreases production of aldosterone. So hypertension is going to make a resurgence as far as having new drugs very soon. So if you think back, let's just go back and wrapping this up to John Doe. Remember, he's that 47-year-old black man with a history of hypertension and chronic kidney disease. He was on a thiazide diuretic, strong family history of early heart disease. He had that early coronary artery calcium score. He's only on hydrochlorothiazide 25, and his blood pressure is 142/88. He's in stage 2 hypertension. What would we do next? And I guess, if you're thinking back on this, that kidney disease should really drive you. It should drive you to a few things. Definitely get the blood pressure to less than 130/80, and the kidney people say less than 120 for the systolic. But also remember, he needs an ACE inhibitor or an ARB to protect that kidney. So I don't care which one. With that kidney function and that albuminuria, he's going on either an ACE inhibitor or an ARB. Pick one. ARBs have maybe fewer side effects than ACE inhibitors. They both require potassium monitoring and kidney monitoring, but this person needs aggressive management. And I would not be surprised if this person ends up on both hydrochlorothiazide, an ACE inhibitor, or an ARB, and also what else? A calcium channel blocker like amlodipine. I think he's going to require 3. Whole bunch of other opportunity for intervention in this person. Some take-home points before we revisit these polling questions are: remember that an ACE inhibitor, ARB, one of those two, calcium channel blockers, and thiazides as 2 other agents are the recommended top 4 agents. Use combinations of these 3 before we go into other ones. Remember that our blood pressure goal is less than 130/80 in most patients, and that's according to our ACC recommendations. There are other organizations that advocate a little bit higher, but there are health benefits to be achieved if you get to this blood pressure goal. And most patients will require a combination of multiple drugs. Remember to rule out other causes when you have a patient with resistant hypertension. And in resistant hypertension, they should be on that thiazide, calcium channel blocker, and either an ACE inhibitor or an ARB before you step down in therapy. Or step up, I should say. And the drugs thereafter are pretty much spironolactone. And that's when we think thereafter of a beta blocker, and then maybe hydralazine, and very lastly, minoxidil, maybe clonidine transdermal, or aproposentant as a newer, more expensive agent that might be considered. Let me address some of these questions as you're teeing that up a little bit. Let me just answer some of these really good questions. One person shed in here. They work in an inpatient setting and they have providers that they don't like using hydrochlorothiazide because of electrolyte abnormalities, and of course, usually think of potassium, but they're actually calling out hyponatremia. Hyponatremia absolutely occurs with thiazide diuretics, and we deal with that in Colorado too because of the high altitude. It's something that actually is definitely an issue or a problem or something that we deal with. I think if you use lower dose hydrochlorothiazide, though 12.5 milligrams, I see a lot less hyponatremia. It seems to jump up when we go to 25. I don't avoid using hydrochlorothiazide because of that. I'm less likely to switch to chlorthalidone because of that, but I'm also less likely to push it beyond 25 milligrams. I still see clinicians using 50 milligrams of hydrochlorothiazide, and that's where all the electrolytes can be a little bit more problematic. So I definitely get what this anonymous attendee actually is saying, but overall I still endorse, but I try to use the lower doses, and lower doses in combination work pretty well. I still don't see the Oprah. So I don't have a preferential use for the carvedilol ahead of them, but I view it pretty equal. It does give you a little bit more kick in blood as far as blood pressure lowering because of that alpha receptor effect. And lastly, do you find yourself reaching for a Plerinone in your patients when you're concerned about gynecomastia with spironolactone use? I'm not yet there. We still use an awful lot of spironolactone. But if a patient does complain at all about gynecomastia, we switch. Prevalence is about 10%. And we know with a plerinone, it does not occur, 10% being gynecomastia. So that is one thing that I do think about. Let me find on here. Let me get the questions that I sent in because I don't have those responses. Let me see one thing. I have a Word document of these questions. We should see, does everybody see a Word document up?
Yes.
And I believe these are yes, this should be it. So the first one was you had a 68-year-old patient. It was a woman who had a history of hypertension and a myocardial infarction last year. She's a smoker. Her blood pressure was pretty bad. She's very adherent with her antihypertensive regimen, which is lisinopril and amlodipine. But with this bad of blood pressure, what you're going to do? What are you going to add to her regimen? Here is a good use of a beta blocker. The reason why I would use that is because she has a history of a myocardial infarction. So she has that stable ischemic heart disease. Normally we wouldn't use a beta blocker, but this is a good reason to do it. Diltiazem, I wouldn't want to add on because she's already on one calcium channel blocker. So using two together, we usually don't do. Adding a hydrochlorothiazide normally be really, really tempting, right? Because it's part of the first three, but this is one where there's a compelling reason to use a beta blocker. That's one of those nuances that I wanted to make sure that educational point was really solid. And spironolactone would probably be my fourth drug, but she's only on two. So I put that in my back pocket for now. The second question was, what is the ACC/AHA recommended blood pressure goal for a person with hypertension and these other bad things? Well, I don't need these other bad things to be there because they recommend less than 130/80 for really everybody. There's maybe just for the healthier people, it's a lower confidence recommendation, but it is the same blood pressure goal standard 130/80. Question number 3 was a 44-year-old black man with hypercholesterolemia and was just diagnosed with hypertension. His blood pressure, ooh, look at this is bad. This is actually stage 2 hypertension. Look at that diastolic. Ooh, it's in the 90s. That's stage 2. It looks like it might be stage 1 based on the systolic, but this is a younger person hypertension pattern, and he's only 44. And this is, consistent that his blood pressures are those ranges. His 10-year risk score is 8.2%, so he's intermediate risk. He's overweight. He's a smoker. He drinks too much. This is this is weekly, so it's not so bad. If it was 2 to 3 a day, that'd be a problem. He eats very healthy, exercises 3 times a week. Which of the following is the most appropriate treatment? This is a person that falls through the cracks. He's following a good, healthy heart lifestyle. So don't do lifestyle modifications alone. And you know what? What's recommended in this patient? He's presenting. He's in stage 2 hypertension. He doesn't need 20 millimeter mercury reduction in systolic, but he needs more than 10 in his diastolic. This is somebody, I wanted to put this here because your stage 2s, especially with this amount of diastolic elevation, to get that less than 80, he's going to need 2 drugs. This is recommended. And you may not think of it because he's so young. The last question I have for you here was, which of the following statements is true regarding regarding recommendations for drug therapy according to that scientific statement? Well, let's see. One is wrong because beta blocker therapy is used before mineralocorticoid receptor antagonists. Nope. Contrary to popular belief, for resistant hypertension, these are recommended ahead of a beta blocker. The second one's correct. When you use clonidine, use the transdermal formulation. I didn't have it written on the slide, but that was a really important one. Minoxidil is end of the line. It's not recommended ahead of hydralazine. It's recommended after hydralazine. And lastly, what's here? Replacing chlorthalidone with hydrochlorothiazide is recommended. Now, this is just I don't like the step 2 recommendation, but it's not what's said here. In the step 2 was to switch hydrochlorothiazide to chlorthalidone, not the opposite. I think that actually both of these long-term are probably equal, contrary to what we've thought about for several years. And Lisa, was there anything that you wanted to announce before we leave?
Nope. I just wanted to say thank you, Dr. Steen, so much for your presentation. It was very good. excuse me for having some technical difficulties there. I did put some links in the webinar chat for everybody. If you want to share the CE codes, Dr. Saseen,
Yep.
everybody can log in. I will have these posted on our website as well as our YouTube page as well. And you can contact me. I have my email information in there if anybody has any questions or follow-up from today. In the chat are our future sessions. We have several coming up for chronic disease. And thank you for your participation today and your expertise, Dr. Steen. That was very good.
Thank you so much.
Okay, take care, everybody. We made it an hour. Have a great rest of your week. Bye-bye.